So, thank you very much, sir, for those kind words. And the head of the strabismus will always remain you, sir. Your presence will always be always there on our department for many years. And thank you for having me here. And much of the work I'm going to show is, of course, always being there with the presence of sir and his guidance. So I'll be talking about management of third nerve palsy. And we know that especially complete third nerve can be quite a challenge because 4 of the 6 muscles are affected, and we are quite hard pressed to actually use only 2 muscles, one of them being the superior oblique, to actually manage. But thankfully, over time, we have started getting more options, and the management options for third nerve palsy become maximal or supramaximal recess resect procedures in the same or in the other eye. This, of course, is possible if there is some function in the muscles. The lateral rectus periosteal fixation with a large medial rectus resection. Medial globe anchor to the medial orbital wall with a large lateral rectus recession, especially to free the force suction test. And medial transposition of the lateral rectus in its various modifications. So I would be saying that more often or very frequently, we are able to manage with a supramaximal recess resect procedure. So we must remember that in a paralytic strabismus, the competent surgical rules do not actually apply. So the limits that you generally place for a competent strabismus would not be true here, and you may have to do a much larger amount of surgery. So you could do the involved eye or the other eye. So if you have good movement, so you have some amount of medial rectus function showing that the eye is crossing the midline, although still falling short. So this was a partially resolved third nerve. You get a fairly good result by doing supramaximal recess resect. The advantage, of course, is that the fair amount of motility that was there preoperatively can be preserved. The same can be used in the other eye if there is again motility in the paratic eye, if there is an aberrant innervation. So especially if the upper lid gets innervated from the misdirected fibers from the medial rectus, and you get an elevation of the lid on attempted adduction, you are able to use that by operating the opposite eye. So besides getting the correction on the deviation, you are able to augment the upper lid elevation and therefore correct the ptosis. So this is not possible if you operate the ipsilateral eye, because there is no innervational change that is happening. So the fixation durex procedure helps us to use this to the advantage of correcting ptosis. When you're looking at complete or virtually near complete third nerve palsy with very poor medial rectus function, you know that any amount of recess resect procedure is not going to actually benefit, and any amount of removal of the tendon and even some myofibrils is not going to provide any muscle action on the medial rectus. So there we are looking at alternative procedures. We can do one option is, if there is some medial rectus function, you can completely remove the lateral rectus action. So it's like an infinite recession of the lateral rectus. It's fixed to the periosteum. The advantage of periosteal fixation is that it is a potentially reversible procedure, and I have actually had to reverse the procedure, and I could find the lateral rectus and replace it. So like I said, it can be a reversible procedure, and you can also, along that, you can do a medial rectus resection, which will help us. So here you can see that you have a very little movement on adduction, attempted adduction, and post-operatively you can see that a reasonably good alignment is possible, and the medial rectus resection also allows us to get some adduction in adduction movement in. So of course there will be loss of abduction because the lateral rectus is no more active now, but at least you have good primary gaze alignment and a fair amount of adduction and convergence, which can be useful in a seeing patient. However, if there is very, very poor medial rectus function, you can see that despite, so there is hardly any medial rectus function, despite a large resection along with the periosteal fixation of the lateral rectus, the outcomes are not very good. So in these cases, your options now shift to the medial side, where you have two broad options of globe fixating procedures onto the medial periosteum, or a transposition of the lateral rectus, the only rectus that is actually functional, to the medial side. So the medial periosteal anchor, I prefer to use the precurruncular approach because I don't like to go through a lot of skin surgeries and all. but it's a very fast approach. You immediately get to access the medial periosteum, and then rest of the procedure is similar, like a medial rectus exposure from a limbal opening, and you can pass the sutures, make a tunnel, burrow a tunnel through, and you can pass sutures from there. So this was one of the patients whom we had done a medial periosteal fixation, an extremely effective procedure. You can correct very, very large deviations, and essentially you have the advantage of this is it's fairly predictable. I would always slightly overcorrect in the intra-op period, about 10 degrees or so, to catch the exodrift that happens as the periosteum kind of lifts up and the sutures loosen up a little. So over time, there is a very long period of stability of this and very good results, especially in very large exos, which have very poor medial rectus function. The final procedure I will talk about with multiple changes that we have seen evolve over time is the lateral rectus transposition medially, and which had been in picture for a fairly long period of time. But Gokikit was the one paper that actually revived the interest into it. And the basic problem with the medial transposition of a split lateral rectus was that the results were less than optimal. So the basic reports were there was a fair bit of undercorrection that was seen, and Jaspreet from PGI had actually recommended that combine it with a medial rectus resection, which is also a fairly good option. So the change which we did was in the medial transposition of the lateral rectus, we added an augmentation suture to the superior slip and the inferior slip. The other key thing that we also observed was that the split has to be very far back so that it does not impinge on the globe, cause pressure on the vortex veins or on the optic nerve, which can cause loss of vision or choroidal effusions in the post-op period. So it's very important to dissect almost 14 to 15 millimeters from the insertion so that it wraps around. And the other thing which I prefer to do is to take it from underneath the superior rectus superior oblique and inferior rectus inferior oblique, so that you can get it to transpose medially from a very far back period. If you have the superior oblique, your muscle will come like this and then wrap around like this. So obviously it will be tighter, tougher to mobilize to that extent medially. And you may often have to suture it much more closer to the lateral rectus and not as close to the medial rectus as possible. And posterior fixation may not be possible. So this is one of the patients of the same procedure which we did. So you can see the split lateral rectus provides some very, very good alignment. If you have a vertical deviation, you could do a full transposition of the muscle from one direction, which helps to correct the vertical. The advantage is, as you can see, this was an exo with hyper for a third nerve. We transpose the lateral rectus from inferiorly underneath the inferior rectus inferior oblique and full muscle adjacent to the medial rectus. This brought some very good vertical correction, but the horizontal correction was a little less than optimal, not as great as what we see in the split transpositions. This was from the superior. You can see the hypotropia and you can see the correction of the hypotropia, but again, slightly not so great correction of the horizontal. And finally, we realized that sometimes the results may not be so optimal with a fixed procedure. So adjustable procedure was something that we thought of. It was already being reported by Ankur Shah et al. But we realized that when they place it on the same side of the medial rectus, you can recess it, but you cannot advance it. So we use the cross fixation technique, wherein the inferior slip was tied superior to the medial rectus and the superior slip tied inferior to the medial rectus, making it adjustable for both horizontal and vertical. So if you want to adjust horizontally, you advance both the slips. If you want to adjust, you have a little residual hypertropia, you adjust the superior sutures, which is actually the inferior slip, and tighten the inferior slip and bring about an increased inferior vector. So essentially, these are patients we had done for adjustable retraction. So finally, factors affecting surgical decision would be whether it's complete or incomplete. Is there any aberrant regeneration to it, where we can use that for our advantage? Is the patient actually willing for other eye surgery? Because often they are not. And finally, choose the appropriate surgery. We can see that there is some graded response of each surgery. LR2-MR can help us to manage vertical deviations, mild vertical deviations in a split LR2-MR, and full transpositions in a complete transposition. And I use periosteal anchor where the FDT is tight of the lateral rectus, and definitely in resurgery. So any previous surgery we have some very good results in a medial periosteal anchor. So thank you very much for the opportunity and listening.